Hello, Assalamu alaikum viewers. I am Dr. Imran Morshed. Today I will talk to you regarding head injury management. Today I will talk to you regarding head injury management. The topics will include the determination of grading of head injury, that is the head injury is minor, mild, moderate or severe in nature, when to do CT scan, when to refer in specialized neurosurgical center, when to discharge the patient, when to do surgical intervention, and post head injury effects. So, these are the topics I will talk to you in this video. I hope you will enjoy the session, and let's start. Approach to a head injury patient management. Any injured patient, any traumatized patient should be managed according to ATLS protocol, that is Advanced Trauma Life Support Protocol. It comprises the primary survey and simultaneous resuscitation, secondary survey to identify other injuries, and definitive care and transfer. At first I will talk to you regarding the history taking. You are seeing the first aid flashcard, ample history. It is very much important to take these histories. These are very important part in management of head injury patient. Ample stands for A for allergies, that the patient is allergic or not. Medication, the patient is whether the patient is taking any anticoagulant therapy or any other medication. Post medical history, that is patient is suffering from asthma or COPD or ischemic heart disease or not. Last oral intake, events prior to the incident, and this history should be taken from the bystanders and paramedics. And it is important to take mechanism and energy involved in the head injury, that is speed of the vehicle and height from he or she fallen. This will help you to determine the head injury grading. And the primary survey. Primary survey, you all know that the ABCD management in trauma care, and now it is revised, that is CABCD. C for control of massive external hemorrhage first, then ABCDE. A for airway with cervical spine protection, B for breathing and ventilation, C for circulation and hemorrhage control, D for disability assessment, and E for exposure in optimal temperature. And in head injury patient, it is important to see the pupil size and response along with Glasgow Coma scale as soon as possible, and focal neurological deficit. These are important parts in primary survey. And the pupil will be progressively fixed and dilated, because ankle herniation can compress the third nerve comprising the parasympathetic supply to the pupil, and of course sympathetic activity produces a sluggish enlarged pupil, and which leads to progressively fixed and dilated pupil. And this is the slide of Glasgow Coma scale, EVM, that is eye opening, verbal response and motor responses. Eye opening for 4 score, verbal response for 5 score, and best motor response for 6 scores. And this is used in grading of head injury. Minor head injury is defined as the GCS 15 with no loss of consciousness. Mild head injury, GCS 4 or 14 or 15 with loss of consciousness. Moderate head injury, GCS 9 to 13, and severe head injury GCS 3 to 8. And any patient suffering from head injury with Glasgow Coma scale 8, it needs emergency intubation and other processes. Neurological deficit, focal neurological deficit, which maybe that is paraplegia, may be evident at the primary survey. Now I am going to secondary survey. In secondary survey, these are important to see that the raccoon sign and battle sign, which indicates the patient is suffering from scalp fracture or not. Raccoon eyes is the periorbital bruising and battle sign is the periauricular bruising. You are seeing this in the picture. That is the raccoon sign. This is the battle sign. Along with this, cervical spine fracture are very much common and must be excluded in the secondary survey. Log roll to check whole spine for steps and tenderness. And per rectum examination, that is important when you are suspecting the patient is of head injury, may suffer from any new spinal injury. You must do per rectal examination because reduced anal tone may be evident in your per rectal examination before doing CT scan to identify any spinal fracture. This and the investigation, baseline investigation, you all know. These are adjunct to primary survey, blood grouping, RH typing, full blood count, RBS, serum creatinine, urine analysis, serum, electrolyte and ABG, arterial blood gas analysis. These are the very baseline investigation. And now I am going to specific investigation like skull and cervical spine X-ray, cranial CT scan, brain MRI, transcranial Doppler. Among the investigation procedure, the CT scan is the considered as best diagnostic tool, as it will allow you to rapid diagnosis as well as to take decision whether the intervention is needed or not. But it's in our mind that when to do CT scan, the indication of CT scan. It is nicely clarified by NICE guideline, that is National Institute for Health and Care Excellence guideline for computed topography in head injury patient. That is within 1 hour we have to do cranial CT scan in the following situation, that is GCS less than 13 at any point, GCS less than 15 at 2 hours, focal neurological deficits, suspected open, depressed or skull-based fracture, more than 1 episode of vomiting, post-traumatic seizure. So these are very important indications, emergency situation when to do CT scan. And indication of CT scan within 8 hours, that is the age more than 65 years, coagulopathy, dangerous mechanism of injury, fall from height or road traffic accident, retrograde amnesia for more than 13 minutes. These are the indications. And now after following evaluation, now I am going to the management part of the presentation of head injury. The goals of management are as follows: prevention of secondary brain injury, control of intracranial pressure, endocrine and metabolic management, control of seizure, nutrition, peptic ulcer prophylaxis, antibiotic prophylaxis and tetanus prophylaxis. Now I am going to describe this in elaborately. Firstly, prevention of secondary brain injury. In the picture we are seeing that brain swelling and mass lesion contribute to raised intracranial pressure. Intracranial pressure is rising, which will contribute to reduced cerebral perfusion and which will cause hypoxia and permit secondary brain injury and necrosis and again rising of intracranial pressure. This is a vicious cycle. So how to prevent secondary brain injury? The tools are avoidance of hypoxia and hypotension and control of intracranial pressure. Now you are seeing the CPP, that is cerebral perfusion pressure, which is normally 75 to 105 millimeter of mercury, is calculated by mean arterial pressure minus intracranial pressure. Mean arterial pressure is 90 to 110 normally, which is calculated from diastolic blood pressure plus 1/3 of pulse pressure, and intracranial pressure, that is normally 5 to 15 millimeter of mercury, which is the pressure of CSA, brain matter and blood vessel. And we are seeing that ICP, intracranial pressure, which is normally 5 to 15, and when it rises above 10 to 25 millimeter of mercury and cerebral perfusion pressure uh, which is normally 75 to 100, we must maintain 60 millimeter of mercury in neurointensive care to preventing head injury, to prevent secondary brain injury. This is very much important. And now I am now telling that how to control intracranial pressure. Previously I have said the importance of controlling intracranial pressure. Now I am telling the measures. Initial measures are as follows: control head up to 20 to 30 degree, loosen collar which doesn't restrict venous drainage, optimize ventilation, optimize electrolyte balance, treating hyperglycemia, sedation by opioids and barbiturates, and seizure control. Intermediate measure, you are seeing that mannitol 20% 100 ml as a bolus dose. Repeated use is controversial, that may cause hypovolemia and hypotension. And final measures, these are the surgical measures. You are seeing that early evacuation of focal hematoma in extradural hematoma and subdural hematoma by bar hole or craniotomy, decompressive craniotomy, and CSF drainage by insertion of extraventricular drainage. And these are the, you are seeing that this is the picture of extraventricular, external ventricular drain. It is commonly named as ventriculostomy or extraventricular drain, which is a device used in neurosurgery to treat hydrocephalus and relieve elevated intracranial pressure when the normal flow of CSF within the brain is obstructed, that is obstructive hydrocephalus. When a brain injury causes obstructive hydrocephalus or brain tumor causes hydrocephalus, this procedure is commonly used. And you are seeing the craniotomy and craniectomy, decompressive craniectomy. These are the picture and differences of craniotomy and craniectomy. In craniotomy, the bone flap is returned to its previous place, but in compressive decompressive craniectomy, the bone flap is not returned to its original place. And I have told you the craniotomy and craniectomy or extraventricular drainage procedure for head injured patient. Now, when to do this? What are the indications of doing surgical decompression? These are GCS scale decreased by 2 or more points between the time of injury and evaluation. Patient presented with fixed and dilated pupil, ICP exceeds 20 mm of mercury, clot collection more than 10 ml, midline shift more than 5 mm. These are very important. And you are seeing very interesting picture, that is the extradural hematoma and the subdural hematoma. This is a diagrammatic presentation. In extradural hematoma, it looks like lemon shaped or biconvex shaped hematoma. It doesn't cross the suture line. It is mainly arterial blood. But in subdural hematoma, it is a crescentic shaped lesion. It crosses the suture line and it's mainly venous blood. I hope you got it. I am going to this next slide. Extradural and subdural hematoma. You are seeing that extradural hematoma picture and with a mass lesion and causing the midline shift. This is a picture of patient which needs surgical intervention, as there is the midline shift. In a previous slide, I have said you the indications of surgical decompression, in where I have said that midline shift more than 5 mm needs emergency surgery, and I am again saying you that midline shift more than 5 mm, clot collection more than 10 ml, ICP exceeds 20 mm of mercury, presented with fixed and dilated pupil, and GCS decreased by 2 or more points at the time of injury and evaluation. This is the picture of barhole operation. Following doing barhole operation, extradural hematoma is evident and a linear skull fracture. You are seeing that in the picture. This is subarachnoid hemorrhage. Blood collects in the circle of Willis, cisternas and fissures. You are seeing that. So blood collected in any space, any subarachnoid space, anywhere. It is pontine cisterna, interpeduncular cisterna, prismatic cisterna, cerebromedullary cisterna, superior cisterna, anywhere. And you see, I am seeing the diagram. Anywhere of the subarachnoid space, it will cause where CSF circulates is called subarachnoid hemorrhage. And the causes of subarachnoid hemorrhage you can commonly remembered by the mnemonics BATS, BATS, Berry aneurysm, arteriovenous malformation, that is rises from the adult polycystic kidney disease, trauma and stroke. Trauma is our main concern in this topic and most commonest cause of subarachnoid hemorrhage. Patient will suffer from the thunderclap headache or the worst headache in his or her life, and with neck stiffness, that which the patient suffers vasospasm and which causes neck stiffness. These are the clinical signs for subarachnoid hemorrhage patient. And this is the picture of CT scan that hyperdense shadow of intraparenchymal hemorrhage with the extension to lateral ventricle. And in the management part of subarachnoid hemorrhage, craniotomy or decompressive craniectomy is not preferred. Here endovascular treatment, that is clipping, is chosen whenever possible in higher center. Now I am going to intracranial hemorrhage. You all know that 10 to 15% of all stroke patients and with 40% mortality occurs as a context of hypertension, amyloid angiopathy, or as a complication of ischemic stroke, presented with neurological deficit with or without decreased consciousness level. High blood pressure should be reduced with care. Anticoagulant should be reversed at once. This is very much important part. Anticoagulant should be reversed at once or stopped. Craniotomy and evacuation is specially considered in young patient, not all patient. And this is the slide for endocrine portion management. Electrolyte imbalance is very much common in traumatic brain injury and contribute to brain swelling, causes seizure. And cerebral salt wasting or Sears syndrome is occur in head injured patient. So there is patient may suffer from hyponatremia. So in this setting, we are to use hypertonic solution or isotonic solution. Don't use hypotonic solution, it's a crime. I am again repeating that hypotonic fluids are avoided in this setting, and administration of steroid in severe head injury is associated with increased mortality and morbidity, so not commonly recommended. Control of seizure. Patient may suffer from seizure following head injury, so anti-epileptics, typically phenytoin, may be administered prophylactically to patients with the doses of 3 to 5 milligram per kg per day. But who are the candidate? Those who suffer from depressed skull, presence of intracranial hemorrhage or tears of dura. This patient needs phenytoin therapy. And nutrition, patient must be started enteral feeding within 72 hours to avoid complication of intravenous therapy. Peptic ulcer prophylaxis, antibiotic prophylaxis, tetanus prophylaxis, these are all same for the injured patient. And these are the key parameters to maintain in neuro-intensive care. Partial pressure of carbon dioxide, partial pressure of oxygen, mean arterial pressure, intracranial pressure, cerebral perfusion pressure, and electrolyte sodium, potassium. You are seeing the slide. So I am in the ending of my presentation. I hope you have enjoyed the session, and those who have subscribed the channel, thanks, and those who have not yet subscribed the channel, I request everyone to subscribe the channel. I have taken this information from the Short Practice of Belly and Love 27 edition and RCR's course manual 4th edition and Google Photos. Thanks everyone for patient sharing. Thanks.